Thank you, Dr. Weiss, for that lovely introduction. So today we're addressing ketamine, which is a very, very broad topic, but it's also a very hot topic. So I wanted to go through some objectives and takeaways before we get started. Um, so one, I wanted to give you a general overview of why ketamine was developed and how it works, where it's also known as the mechanism of action. Um, Also, we want to address the different ways that ketamine can be given and how it is used in medicine. What current research shows us about ketamine for chronic pain uh, is also our objective. And ultimately, I want to go into the safety monitoring and the potential side effects of using ketamine therapies. So, growing public interest, I think, has been persistent. Um, Although it was developed a couple decades ago, I think most people haven't heard about it until more recently. And that's due to a variety of different reasons that we'll go into. There is some growth in ketamine-assisted pharmacotherapy, as well as there's spikes in the news due to media attention on famous individuals. So as you see, that ketamine has really been at the forefront of the public interest. And there has been a growing market for ketamine therapy for both chronic pain and for other indications or health reasons. So this growing public interest has led to a growth of direct-to-consumer marketing for a lot of these ketamine therapies. Some of these pair therapies are at home, in which you take either ketamine through the mouth or as a spray in your nose, and you are monitored either remotely or uh, as a regular check-in for some of these companies. And there's also companies that provide in-clinic ketamine infusions through a IV line or intravenous line directly into your bloodstream. And not to go into any of these companies specifically because they all vary so much, um, I just wanted to really highlight the diversity of ketamine therapies out there. And while most of these companies offer ketamine therapy for mood disorders such as depression, PTSD, as well as severe anxiety, the topic we're going to be covering today is really focused on ketamine for chronic pain. And there's also, because of the wide interest in ketamine, there's also been a growth in the medical interest. As you can see here, this is the PubMed, which is the kind of hub of all resources and research that has been done in the recent years. And you can see here that there's really been a very positive slope in growth from 1993 to now. And that's due to a variety of reasons. The broad indications that we're using it for, as well as its mechanism of action. However, despite the growing academic interest, ketamine for chronic pain is really difficult to study. There's no clear biomarkers for chronic pain, and people experience pain very differently. It's also difficult to study the wide variety of causes of pain indications. So it's very difficult to have a very focused study. So ultimately, what happens right now is the growth in public interest outpaces the growth in medical knowledge. And as a result, we really have to rely on some of society's joint consensus guidelines, which is when a group of physicians in the area of this specialization get together and discuss what do we know to the best of our knowledge, especially if a topic is not super clear. So this consensus guideline was published by the American Society of Regional Anesthesia and Pain Medicine, the ASRA, and AAPM, American Academy of Pain Medicine, as well as ASA, the American Society of Anesthesiologists. So these are the most predominant societies. And we'll be referring back to this article throughout the lecture. And to now step back, I want to talk about why ketamine was developed and how it's being used and how it works. Since this is a evolving topic, I think it's best to kind of rewind and look back in history. So ketamine throughout the years, initially when it was first created in a lab in 1962, it was really meant for anesthetic purposes. Um, and the first use of ketamine in humans didn't happen until 1964. Initially, the goal was to find an anesthetic um, or to help people through surgeries and things like that. Um, Ultimately, after some time, the FDA approved it as a general anesthetic. And in the following years, it really had grown popular in use for anesthesia because it is relatively hemodynamically stable, which is to say that it doesn't cause big swings in your blood pressure and heart rate. Um, it was really popular during the Vietnam War era where there's a lot of trauma anesthesia. It's also good for pediatric anesthesia and emergency medicine due to those similar reasons. And in the 1990s, there's been a spike in the research of ketamine for pain because of the mechanisms of action, which we will go into in a little bit. And in the 2000s, there's been an expanded research and use in mood disorders that this trend has continued. And there's been a lot of off-label use, which is using for indication that it's not FDA approved for. But for those things, we will not go into the off-label use. And ultimately, a drug, it's best for us to know how it works. And the ketamine is no exception. Ketamine has a lot of different targets. The most prominent one is an NMDA receptor, which is a receptor in your brain. Um, it's relocated in multiple different locations, but predominantly in the prefrontal cortex, as highlighted here, and in the hippocampus. But this is not its only target. It has many other targets in addition to the NMDA receptor. It has influences on the opiate receptors as well as cholinergic receptors, GABA receptors, and AMPA receptors and monoaminergic receptors. So also, then now we're going to step back and review basic cellular biology. So this will take us back to our high school days. So ultimately, our human bodies are made out of organs and then cells. And then they're on the cells. I think about it as a bag. And then in this bag, the outer layer is the phosphate bilayer. Um, and that's where a lot of these receptors tend to sit. And the cell sends out chemical signals using different molecules, proteins, and electrolytes, and which is an electrical gradient to help it communicate with other cells in your body. And this is where the ketamine acts upon. So the primary mechanism is the NMDA receptor, and it causes decrease in frequency and duration of channel activation. And its overall effect is really limiting the excitatory signals, which can, we know, cause pain. One of these is the wind-up phenomenon and then central sensitization. And when this receptor is inhibited, the decreased activity triggers a major role in changes in chronic pain, in opiate tolerance, as well as mood regulation. And what is wind up? So this is a phenomenon I think most of us have experienced. To describe it more simply, think about your pain. Pain goes up your spinal cord. And when you, for example, step on a Lego, usually it's uncomfortable, but the pain can be pretty mild. However, if this pain keeps occurring and the injury recurs, there's very lots of concern that you'll have the wind-up phenomenon, which is after you step on a whole bunch of Legos, instead of the pain being a 3 out of 10, over time it can feel like significantly worse. It could feel like a 7 out of 10. And are some of the thoughts of the mechanism of action for ketamine is that this helps to limit the wind-up phenomenon. Another way ketamine can, we think about ketamine helping with chronic pain is limiting central sensitization. This is when our nervous system becomes hyper-responsive and amplifies the pain signals, whether the actual cause of injury persists or not. So think about it as if you have an oven that catches on fire and your fire alarm goes off, that can be cause a lot of alarm. Um, but because you are associating this fire with significant damage, your person and your belongings, um, your alarm system is hyperactivated. And then in some people, even a more benign trigger, such as a candle that's controlled and not burning aggressively, can cause amplification of the pain and result in chronic pain. And so that's some of the history and some of the mechanism of how ketamine works. And then there's different ways ketamine can be given and how it is used in medicine. And I think this would be very interesting to some of our patients, just to have a better understanding of what is the experience is like. But unfortunately, ketamine is given in such a wide variety of methods that it's a little hard to summarize. So how much of the ketamine are you getting? And then this is a graph that illustrates the percentage of ketamine you are getting through either on your skin, through oral ingestion, through rectal application, intranasal, under your skin, um, and intramuscular in your muscle and in your vein, intravenous methods. And the x-axis is 100%, from going from 0 to 100%. And towards the right is when you have the benchmark of you're getting 100% of the ketamine through the intravenous option. So because of the massive spread of how much ketamine you're getting, the topical, the oral, the rectal, and the intranasal options, it has uh, such a big contrast between different methods that we're really not going to focus on them as much. And instead, we're going to focus on intravenous options because it's more reliable and steadily gives us 100% um, of the ketamine that's bioavailable. And ultimately, we think about doses. So dose varies based on clinical use. For general anesthesia, you will need significantly more ketamine than you would need for pain indications. And even for different indications, if you increase the amount of ketamine someone is getting, you will induce general anesthesia if it goes too high, which can lead to a lot of the problems and the requirement for monitoring. And what are ketamine's FDA approved uses after we talk about how it's given? And the surprise is that it's really only FDA approved for general anesthesia and treatment-resistant depression. So does this mean that we can't use ketamine for different indications other than these two? And the answer is really no. But just because uh, there's a lot of unknowns about ketamine. And especially in chronic pain, there's many medications that we use for pain that isn't FDA approved, such as amitriptyline, which is a very commonly used medication for pain. But so it leads us to a scenario in which that there might be a lot of things we don't know about ketamine. And there are it's really a growing area. So I like to think about it like this. For those of us who have played video games, oftentimes you start off in an open world game without a whole lot of information, and you don't know where anything is, and your map is very limited. And ketamine for chronic pain is very similar. Um, just because our light source is the amount of research we have done, um, that doesn't mean that we're ultimately only limited to a specific indication. So I like to think that with time and additional research, we can expand uh, the clinical evidence and the guidelines of how to use ketamine for chronic pain. So right now, the areas that have been studied for ketamine is complex regional pain syndrome, or CRPS, pain due to spinal cord injury, ischemic limb pain, fibromyalgia, headaches, as well as cancer pain. And hopefully, with more research and time, we can expand and replace some of these question marks with additional indications. So it's really an area of uh, growth. And because of that, I wanted to also look at what current research shows about ketamine for chronic pain. Because of the limited evidence and the trials, we often have to also rely on expert opinion as demonstrated in the consensus guidelines from the medical societies. So what we know, let's start off easy. So ketamine for surgical pain. We know that for major surgeries, it can help reduce opiate consumption when given with general anesthesia, reduce postoperative pain levels, and at 24 to 48 hours. There's also studies with patients who rely on long-term opiate therapy. For these patients, they demonstrate a reduction in postoperative and long-term opiate use after spine surgery. And this, the primary outcome, what they measure is pain at and the medication use at 48 hours. But this study also shows that some of the benefits extend up to weeks afterwards. So obviously, this is very encouraging information. But unfortunately, we have not had uh, as much time to study ketamine for chronic pain. So we have to also then rewind and look at the levels of evidence. Ideally, the top of the pyramid is where what kind of evidence we want to guide our clinical decision making. However, these meta-analysis and large randomized controlled trials are very expensive and time intensive to conduct. So we don't have so much of the high levels of information. As a result, we have some limited uh, results from the studies, and as well as limited number of studies. And furthermore, um, we can put those studies together and give us a meta-analysis and looking at a higher level of evidence by making some conglomerate um, uh, uh, conclusions from the individual studies. But it also can be difficult because individual studies are difficult to compare. And why is it so hard to study ketamine chronic pain? Part of it is because of chronic pain is difficult to study. There's a mixed patient population who have pain from different reasons, um, difficulty in capturing the pain experience. For example, there's in two people who both have back pain and both have had surgeries for the same MRI findings. One person can experience pain significantly worse and have them impact their daily life and may not be able to return to work, whereas someone else might have uh, a lighter impact on their life. And ultimately, it's also very difficult to study chronic pain because of the extended follow-up timeline. A lot of patients who enroll in these clinical studies move and and are lost to follow-up. And a placebo effect, which is, I think, something that a lot of us are aware of, as an effect that even the sugar pill effect, even if you're not getting a medication because someone is expecting them to have a benefit from the um, placebo, you feel like you might also have a better experience as well. And then the placebo effect for chronic pain is very high, and this is causes a problem for studying a lot of different treatments for chronic pain. So ketamine itself is also difficult to study because of the very bioavailability in taking it in different routes from the very low absorption from skin topical uses versus the more reliable bioavailability by ketamine through the intravenous route or IV route where it goes directly through your bloodstream. And ultimately, because there's no standard protocol, it's very difficult to compare the outcomes of all of these different studies. And it's also difficult to blind the patients um, to see, to prevent the patients from knowing that whether they're getting ketamine or not because of some of the side effects. So while it's difficult to study, we have been studying ketamine using a variety of visual analog, pain scales, functional scores, and quality of life scores, and emotional measurements to study this very difficult to understand subject. And this is a really illustration of why there's no standard protocol for ketamine infusion. Some studies use single infusions where you go into the clinic for one day for a couple of hours. You have a IV placed and you go home the same day. Whereas there's other studies that have daily infusions for a couple of days, and you go home in the end of each day, and those can happen for 5 days. And it happens sequentially and repeatedly for some patients, but not others. And some protocols use a continued 5-day infusion in which a patient would be stay in the hospital and have continued monitoring for those whole 5 days of ketamine therapy. And because this is such a um, difficult to study subject, we always wonder, is there a dose relationship between ketamine and the benefit to chronic pain? And the answer is it's not super clear. So for this graph, that on the bottom line is the axis. On the right, towards the right of the graph is where there's a higher amount of ketamine being given. And on the left is where there's a smaller amount of ketamine being given. And on the y-axis, the vertical bar, there is demonstrates the duration of benefit. And you can see if you really squint, there's loosely a correlation. However, ideally, we would like our graphs to be more tightly clustered and be more clear. So ultimately, there might be a dose re response relationship. However, it's a very loose relationship right now. And ultimately, going back to the guidelines from the societies, um, we have ketamine as indications with spinal cord injury, CRPS, neuropathic pain, fibromyalgia, cancer pain, ischemic pain, headache, as well as spinal pain. But the level of evidence is really not certain, as you can see on the right side of this table. For some indications that's more studied, such as CRPS, there is a grade B or low to moderate certainty. Whereas for some of these other indications, is grade D with low certainty as an indication for fibromyalgia, cancer pain, ischemic pain. So where does that lead us? Ultimately, that evidence is really limited, and so it's really up to your it's a really a discussion between you and your pain physician to see if this is an option for you or a loved one. And thankfully, there are some things we do know about ketamine. The safety and the potential side effect is something that we gain a lot of information from the use of ketamine in general anesthesia. So there are short-term side effects and long-term effects. So in the short term, someone can have high blood pressure as a result, as well as an elevated heart rate. Um, there's also risks of hallucinations, in which you're seeing things that are not there. They don't necessarily have to be um, scary hallucinations, but for instance, I have had incidences of my patients seeing pink elephants. There's also risk of nausea, vomiting, um, and visual disturbances, such as uh, change diplopia, where you're seeing two things at once, as well as possible headaches being triggered by ketamine, and feeling tired and sleepy and difficulty urinating. And there are some long-term side effects of ketamine, except especially in susceptible patients, there is risk of liver damage. Um, there can be irritation and inflammation of the bladder with chronic use. And with chronic use and long-term use, there can be tolerance and dependence, especially with at-home ketamine use, during which you're not immediately monitored by a medical professional. And so, because of all these side effects, we like to monitor our patients safely at Stanford. So, we put everyone on blood pressure monitoring as well as oxygen monitoring and have nurses check for level of awakeness or level of sedation. In addition, we make sure that everyone has a urine drug test because there is a risk of addiction in home ketamine use. There's also risk of heart problems, so we like to get EKG, which is a rhythm strip for patients with high cardiac risk. Um, Furthermore, for patients with baseline liver dysfunction, we also like to get a liver panel test. And we do manage a lot of these side effects noted in the slide before by giving antiemetic medications. Some of you might be familiar with Zofran, which is a common one we give, as well as blood pressure lowering medications, as well as anti-anxiety medications. And ultimately, there's also instances when ketamine is not a good fit for patients. And that these really are patients with other comorbid or in general health problems that makes it unsafe. Um, so some of these include uncontrolled heart problems, as active chest pain, um, really elevated blood pressure already at baseline, um, and as well as people with history of intracranial hypertension, which is increasing uh, pressure in your brain, hyperthyroidism to a degree, as well as liver damage, as and history of psychologic conditions and history active substance abuse. So, what are the key takeaways? Unfortunately, this is such a fast-growing topic, and it is a difficult topic to tackle because we also have very limited research to guide our clinical decision making. But ultimately, my hope is that with time and more resources, we can have a better understanding of ketamine and how it affects chronic pain. Ketamine should always be given in a safe and monitored setting by trained medical professionals. This is a super important takeaway, and it really will really kind of set the course of anyone's ketamine therapy. And here are my references. And these are some of the additional classes and group resources that our pain psychologists have compiled for everyone. So thank you.